Thank you very much. This is the logo for the Diabetes Control and Complications trial. And as I was listening to Bill Hagopian and Oka's comments about TEDI, I thought, well, the DCCT is in marked contrast, namely their study, TEDI, is studying people who don't yet have diabetes. The DCCT was designed to study how to make lives better, how to reduce the complications of type 1 diabetes. And the TEDI study is still very early in its ongoing, whereas, as you see from the title of my talk, the DCCT is 30 plus years, now 31 years since the beginning. And this just gives you a hint of the timeline. There was a national commission back in the late 1970s, and as part of a law, they decided that they needed to perform the Diabetes Control and Complications trial. There was a request for applications in '82. In '83, the study began. And then in 1993, 10 years later, the results of the DCCT were published. And then, as you can see, EDIC, the Epidemiology of Diabetes and its Complications, has been ongoing ever since, namely following the people who are initially randomized into the DCCT. Now, this is a slide of the investigators. And I'm in there.
Find Waldo.
If you haven't yet found me, I'm in the very back row on the, I guess it would be on your far right. No, on your far left. So the question that we were asking in 1983, is treatment that normalizes glucose levels, will that prevent or delay the long-term complications of diabetes? Now, I'm sure for all of you sitting there, you say, how did you not know that? That is known now by everyone who is involved in type 1 diabetes. But it was not known in 1983. In fact, there were two big camps. There was a camp on the East Coast that actually thought this was the answer. There was a camp on the West Coast, especially in California, who were championing the idea that the complications of type 1 diabetes were largely genetically driven. And the control was really not that big a deal. And as you'll see, we clearly know that's not the case. Two slides of background. The Diabetes Control and Complications trial randomized 1441 patients from 21 clinical centers in the United States and Canada. We recruited from '83 to '89, and the results were published in '93. The EDIC study, Epidemiology of Diabetes Intervention and Complications, is the ongoing follow-up study of all of the people that were in the DCCT. So what did we do in the DCCT? There were two groups. These are all type 1 patients. They were either randomized to conventional therapy, which at that time was clinical well-being and using 1 to 2 daily injections of insulin with self-monitoring, but there were really no specific targets. And we masked the hemoglobin A1C. The intensive group was, we were trying to maintain glucose levels as near normal as possible, using multiple daily injections or early versions of pumps. We were asking the people to monitor themselves 7 times a day, and every month we measured hemoglobin A1C. Essentially, we were allowed to do most anything we could to the intensive treatment group to try and get them as close to normal glucose control as possible. Now, I just want to make a side point, and that is journals are rated in terms of how much of an impact they have on science. And as you can see here, Journal Diabetes Research and Clinical Practice has an impact factor of 2.5. Two excellent journals, Diabetes and Diabetes Care, have impact factors in the mid-8s. JAMA, Journal of American Medical Association, is 30. Nature is 38.6. And the New England Journal of Medicine is essentially at the top of 51.7. And so the first accomplishment to stress with you that of the 214 publications so far from the DCCT EDIC group, 7 of them have been in the top journal, the New England Journal of Medicine. And I could have made my whole talk on nothing but New England Journal of Medicine articles, but I'm going to divert toward the end because of an area that I think is very worthy of presentation to you. So this was the hemoglobin A1C results in the 2 groups of patients. They entered with a hemoglobin A1C of around 9. Those in the intensive treated group immediately fell. They didn't fall to 6, which would have been non-diabetic levels. They fell to about 7. But as you can see, and then for the duration of the DCCT, those 2 groups of hemoglobin A1Cs were about 2 percentage points apart. Now this was unheard of at that time. When we started the DCCT, people said, you're not even going to find anybody that'll stick themselves 7 times a day and take all these doses of insulin. It's just not possible to do this study. So we actually had to do a feasibility study. But lesson number 1 from the DCCT edict is that intensive therapy can markedly improve and maintain, and that was really the most important part, but not normalize glycemic control of patients with type 1 diabetes. Now this next slide shows you the main results, and that was retinopathy in people with type 1 diabetes. The groups were divided into those who didn't have even 1 microaneurysm, primary prevention, and those that had early retinopathy. And as you can see from this slide, those patients randomized to conventional therapy with a mean hemoglobin A1C of around 9 had much more retinopathy over the course of the DCCT in either the primary prevention or the secondary intervention. Now look very carefully at the beginning years of the secondary intervention, and you will see that those people randomized to intensive therapy for the first few years actually got worse. And it was really to the credit of the oversight committee that they didn't stop the trial. Because as you can see, although there is a transient worsening, and this is now well recognized with intensive therapy, if you continue, then there's benefit out to the end. I would mention that the same kind of results we're seeing for nephropathy, early nephropathy. Carla presented to you some of the later nephropathy data from Ian DeBoer here in Seattle, and also for early neuropathy. But, and there's a but, and that is that the intensively treated patients suffered more hypoglycemia. And here is severe hypoglycemia needing assistance from someone else, coma, seizures, needing hospitalization. No matter how you looked at it, being randomized to intensive therapy, there was a price. namely, and that price was hypoglycemia. And that's why we couldn't get the hemoglobin A1C down to 6. When we pushed from 7 to 6, we got even much more hypoglycemia than was observed with the 2-point differential that we did have in the DCCT. And this is just plotted here. As you can see, as you do better in terms of hemoglobin A1C, going down toward 5, the rate of progression of retinopathy decreases, but the rate of hypoglycemia increases. So lesson number 2 is intensive glycemic control reduces the risk of retinopathy, nephropathy, and neuropathy in patients with type 1 diabetes, but it increases the risk of hypoglycemia. So EDIC, which is the follow-up study, the main objective of that was to ask whether intensive versus conventional therapy implemented during the DCCT, what effect would that have on development and progressions of more advanced stages? Remember, the DCCT was early complications, and on cognitive function, and on macrovascular complications. And so what happened when the DCCT was over? When it was done in 1993, and the results were so dramatic that there was benefit, we were asked, all of the principal investigators in our teams were asked to train the conventionally treated patients in intensive therapy. And so we did that, and then we recommended intensive therapy to everyone in the trial. But the government no longer would pay for the intensive therapy. So during the DCCT, everything was free. After the DCCT was over, these people had to get their health care wherever it was appropriate for them to get their health care. And so what happened is what you would imagine. The hemoglobin A1C in the intensively treated patients rose a little bit, and that in the conventionally treated patients fell, such that for a few years there was separation, but then for the last 10 to 15 years, there's been absolutely no difference statistically between the two groups. So the hemoglobin A1C, which was 2 percentage points different during the DCCT, has now, for the bulk of EDIC, been very similar, or in fact, identical. And so the question is, what's the impact of having had that early window of glycemic control over what's happening during the whole lifetime of these patients with diabetes? Well, one of the big things that folks have worried about is cognitive function. I showed you the increased frequency of hypoglycemia. Now, is this carrying a risk in terms of cognitive function long-term for the people? This was addressed in one of the early EDIC papers, again, published in the New England Journal, and the results were really very good. Namely, that intensive glycemic control is not detrimental to cognitive function in the intensively treated patients. And in fact, for 2 measures, psychomotor efficiency and motor speed, essentially coordination, there was a statistically improvement in those randomized to intensive therapy. Now, one important question is, well, what happens to the retinopathy and nephropathy when the hemoglobin A1C comes together? And I've plotted here 3 hypothetical examples of what might happen. So the first one on your left there is that whatever you started during the DCCT would just continue. That that has such an important effect that it would just continue no matter what happened for the rest of the life of the person. On the other hand, it might be that up on the far right, that just like the hemoglobin A1C came together, maybe the rate of complications would come together. Might take a little longer, but eventually that's what would happen. Or you would just progress on similarly. Namely, you got a separation, and then you went up similarly. Well, what happened, and this now is plotted from the beginning of EDIC. So remember, we've had separation, and then all the patients' retinopathy is taken essentially back to zero, and as you see, it just continues to spread during EDIC. And again, this was true for not just retinopathy, but nephropathy and neuropathy. And so, what we observed is on the left, namely that the early control had a dramatic effect, even though the hemoglobin A1C was the same, on the rate of complications. Now you might say, well, that's preposterous. But here's an example I found. So we've got two folks, Jim and Joe, and they start working at age 25. And let's see, Joe puts $1,000 per month, per year, whatever, into his retirement account, and Jim puts twice that amount in. He puts $2,000 per month in. And as you might expect, they diverge. Now there's 10% improvement here by interest rate also, don't we wish? But then, at age 45, Joe says, you know, I think I'm going to start putting more money into my account. He starts to get worried. What happens? Isn't that amazing? From age 45 to 65, they keep diverging, even though the amount of money that they're putting in and the interest rate is exactly the same. Now, whether this really applies to the complications of type 1 diabetes, I don't know. But nonetheless, lesson number 4 says there is something called metabolic memory, imprinting, legacy. This has been observed in numerous different studies. It's also observed in type 2 diabetes. And the important message, just like for retirement, is initiate glycemic control as early as possible because of the carry forward effect of that control. This is a coronary artery of an unfortunate person who died from a myocardial infarction, a heart attack. And what you see here, the circle there, is the coronary artery. As you can see, there's a lot of atherosclerosis in that coronary artery. And then, unfortunately, there was a clot that formed on top of the atheromata that blocked that artery, causing a heart attack and death. And the DCCT edict looked at, is this intensive control important for the macrovascular disease of diabetes? Myocardial infarction, leg amputations, and stroke. And the answer is yes. Now you can see here at the end of the DCCT, right around years 9 and 10, there was a difference, but it wasn't yet statistically significant. So here we have a much slower process than retinopathy, which was dramatically different. But as you follow these people out now during EDIC, and this is a slide from a number of years ago, so we have another 10 years or so onto it, but there's a 42% reduction for any cardiovascular event. And then if you take ones that are definite, a non-fatal MI, a stroke, or in fact a death, there's a 57% reduction in the risk of having those events if you were randomized to intensive therapy. And we're approaching the time now where we're going to have a follow-up study from EDIC. So lesson number 5, intensive glycemic control reduces the risk of cardiovascular events. Now this is a picture of C-peptide. And the reason for showing it, well, it's really a picture of the insulin, pro-insulin molecule. And the connecting peptide, which is between the amino acids that are not in black and over there to the others that are not in black, that's called a C-peptide. And by measuring C-peptide, you can actually get a clue as to how much insulin is being secreted in people who have type 1 diabetes and who are taking insulin. Otherwise, when you try to measure insulin, you get how much the insulin they're making and how much insulin is being injected. This allows you to get a handle on how much insulin the person is still making. And you've heard from several people today that folks with type 1 diabetes still make quite a bit more insulin and C-peptide than we had previously presumed. Now this was also studied in the DCCT. And what we found was that intensive diabetes control slows the loss of endogenous insulin secretion. So when we studied those individuals who had quite a bit of beta cell function, even though they had type 1 diabetes for over a year, to get into the DCCT, there was preservation of that, and in fact a 57% risk reduction in terms of the rate of fall, rate of loss of endogenous insulin secretion. Now, the ability to still make insulin results in improved glycemic control. So as you can see here on the very far left, that's the hemoglobin A1C that people who had a C-peptide above 0.2 or below 0.2, that's the definition of responder and non-responder. In the community, they had better hemoglobin A1C. And when randomized to intensive therapy, and the patients or the physicians didn't have any idea who was a responder and who wasn't, but for years, you get better glycemic control the more residual C-peptide you have, the more residual insulin secretion. And so there's what might be called a virtuous cycle, namely better diabetes control results in less beta cell damage, preserved beta cell function, and that feeds back on better diabetes control. So it's a win-win situation in terms of endogenous beta cell function. So lesson number 6 is intensive glycemic control preserves endogenous insulin secretion, which results in a virtuous cycle. So what happens in terms of the complications of diabetes? Remember, the people get slightly better hemoglobin A1C. Well, as you might expect, those individuals who were responders and randomized to the intensive therapy group do much better. So here's the responders on the bottom, and above that are the non-responders in terms of retinopathy. Again, early nephropathy and neuropathy show essentially the same thing. But here we have the opposite effect on hypoglycemia. So not only do you get improved glycemic control, but you have less hypoglycemia. And this is just plotted for coma and seizures. So on the far left are conventional treated people, intensive responders with a low rate of hypoglycemia, and intensive non-responders. So it makes a huge difference whether it's your own insulin, which gives you better glycemic control and less hypoglycemia, or exogenous insulin, where the better your glycemic control, the tendency is for more hypoglycemia. And so lesson number 7, in type 1 diabetes, patients treated with intensive therapy and resulting in a responder above 0.2, that's associated with less retinopathy, less nephropathy, but less hypoglycemia. And so in summary, what have we learned? And these are just 7 of lots of things we've learned. The intensive glycemic control decreases the microvascular complications. It decreases neuropathy, decreases macrovascular disease, increases hypoglycemia. It improves cognitive function. There's metabolic memory. What you do early counts later on, and it results in preserved beta cell function. Thanks a lot.